Okay, hi everyone. Can you hear me okay in the back there? Yeah? Okay, we're going to try to not use the mics, but if you can't hear either myself or Dr. Olson, then just let us know. So thank you for coming and welcome. This is the second HRI seminar in our series that we started this year. And as you know, those of you who came last time, we had a really excellent launch with a panel discussion on Indigenous health with Henry Harder, Marco Greenwood, and Sarah DeLeo. This is a slightly different format, and it's our first seminar series where we have just one investigator. So while we've booked in an hour and a half for these sessions so that we don't have people banging on the door to come in, we don't necessarily anticipate someone's just going to stand up here and talk for an hour and a half. I think actually Dr. Olson would like a lot of discussion today, and so he's prepared a talk, but then we will have time for question answers and some discussion. So one of the goals of the Health HRI seminar series was to showcase health research that was going on in the North, to have better communication and a venue for us to showcase our work and try to connect with each other. And when Marco and Chelsea and I were sitting down to figure out who was going to be invited to speak for these sessions, one of the big things is we wanted to make sure we were crossing the health research pillars or disciplines. And so last time, as I said, we had on Indigenous health, and today we're going to move into the area of clinical research and health service research. So with that, then I will introduce the the speaker for today, which is Dr. Rob Olson. Rob's a radiation oncologist and a researcher who's based here in Prince George. He's an associate professor in the Department of Surgery at UBC and also in the Northern Medical Program at UMBC. He grew up in Lloydminster, but did his training or his early academic years in Calgary, where he did his undergraduate degree as well as his medical degree at the University of Calgary, and then moved to Vancouver to do a residency in radiation oncology, and also has completed a master's in epidemiology at the Harvard School of Public Health, or that's the order? Yeah, Harvard School of Public Health. So he started his practice as a radiation oncologist in Vancouver, but came to Prince George to be hired as the first physician at the BC Cancer Agency here, the Centre for the North. And so we're extremely lucky to have him here. And in that position came with it his academic faculty appointment here in the NMP. So we're really fortunate to have him as one of our faculty members in the NMP. And he's got an extremely active research program focusing on 30 active research projects, many focused on health service delivery, but also some on clinical trials for cancer. He holds several positions outside of his role as a researcher. He's the provincial division head for radiation oncology at UBC. He has just recently started as the research lead for the Northern Medical Program. And most recently, he has received funding from the Michael Smith Foundation as in their first health professional investigator program. So I think that's enough of an intro. And with that, we'll welcome Rob. Oh. And just to remind people that are on the phone, welcome and thank you for coming. If you'd like to ask a question, I guess you just interrupt us, or you maybe wait for question time, but we will have some discussion, so please feel free to be involved in that.
Perfect. Okay. Yes, clap. So thanks for introducing me. That's great. If you can't hear me, let me know and I'll put on the mic, but hopefully I talk loud enough. I'm pretty quick always, so if I'm too fast, put your hand up, go like this to slow down. I'm totally happy for you to interject and ask questions and clarifications, because I always forget what level people are at. And radiation oncology is kind of weird, so I might use some acronyms accidentally because I tend to recycle slides in multiple talks. So if you see an acronym, it's not dumb not to know it, because I don't know any acronyms outside of radiation oncology, so why would you know them in radiation oncology? Just put your hand up and ask what it is. The only disclosure I have is I've received some funding from a medical company that sponsored one of my research grants. So this is the outline, but really I want to spend most of the time answering questions if people have them, but I'm going to pick sort of a narrow place for most of the talk, just to pick one of the themes of research that I think has the best story, I guess. In my research program, it ties a couple different areas of health services research together, and is one of the easier concepts to understand. So it's in prescribing radiotherapy for bone metastases. And so sorry for people who've heard me talk before, because I picked this story a lot. But it's not the only thing I research. It's one of the easier ones to tell sort of an example. So I'm going to highlight a clinical problem that emerged within radiation oncology internationally, and then why I chose to do some research on it. So I started with the descriptive health services research about this to see if it really was a problem in BC. So I'll describe that. And then I'll describe what I found, and then how I designed some research programs to intervene and change that problem. And then I'll present the results of that. And then after that, I'm going to give a couple other examples of my research that are completely different than bone mets, just to give you a flavor. Also because I think one of my selfish reasons for being here is to talk about possible opportunities to collaborate and to recruit students, and for you to say nice things about me to other people so I can get collaborators. And so I'm going to use that opportunity to talk about some other research examples that are related to things I've done. Because I find every time I do a research project, I think of another 5 that could come after it. The first thing, just to lay the groundwork with the first half, is about bone metastases. So cancer, most people know that cancer can spread places. It's one of the main foundations of what makes something cancer. And so cancer, goes through the basement membrane and grows into where there's blood vessels and when there's lymphatics. So a pretty common route of spread is going into lymphatics. So breast cancer can spread to lymph nodes. The other really common, actually more common way would be into the bloodstream, and it can spread throughout the body. And because your bone marrow is made in your blood's made in your bone marrow, all your blood is circulating through there, and so that's the most common place for cancer to spread. And so it's a really common indication to give radiation. So just to put it in perspective, in BC, we treat 3,500 a year, going up a bit every year. And so in Prince George, it really is about 1 a day. So we treat about 300 bone mets a year in Prince George and in our center. And so it averages out to that much. So that's the scope of a really common problem, which is useful when you're doing epidemiology research, is things that are large numbers make it easier to pull data and actually answer questions that you've got. The other thing that's important is that the prescriptions are really variable for bone metastases, and so there's variation in how people practice, and I'm interested in looking at how people practice and how we can change practice. And then the 2 big extremes of how you can treat bone mets are giving it in one dose and something we call gray, so 8 gray and 1 fraction, which is really convenient when you live in Prince Rupert or Terrace. Or you could give it like 5 weeks, which is actually really common in the US, but you could imagine that that's not really convenient for somebody who lives at Y. So there's a whole bunch of other variations on different ways of giving radiation, and but like I don't want to emphasize that. And then importantly, there's also evidence to guide which one we should pick. So there's 25 randomized control trials. That's one single treatment, that 8 gray, is just as effective for treating painful bone metastases than giving 5 treatments or 10 or 25 in smaller doses every day. So you really can't get much more evidence than 25 randomized trials. And so this is just to put that, to beat that into people's heads. Cause I'm usually giving this talk to, I actually travel to different provinces and actually try to convince people to change their practice. And so this is a slide that I will remind radiation oncologists, look at all of these randomized trials. So this is a plot that shows the confidence intervals for the intervention of getting multiple treatments versus single. And all of these trials are crossing no difference. And then when you average them all together, there's still no difference. So a meta-analysis has been published on all these 25 randomized trials, more than one meta-analysis. Actually, there's been guidelines that have come out about this. Choosing Wisely Canada is this area where we try to give physicians some guidelines on how they should practice. One of them would be don't give antibiotics for sore throats. And so radiation oncology is common enough of an indication it makes it into there. And the one they chose for radiation oncology is don't give more than a single fraction. So lots and lots of evidence. So I didn't need to do my research career to do a 26th randomized trial. It's not what was needed, and actually probably unethical. But despite this, there's a huge variation in how people prescribe. So less than 5% in most jurisdictions in the US, and that's probably because they get paid more to do it. That is not an issue in most of Canada, certainly not in BC. We're on salary. I like to work as less as possible. So I wouldn't give, I have no motivation to give somebody treatment that they don't need. And in most of Canada, Thankfully, that's the way we're structured. We're on salary, and so that's not an indication. But there's still variation in other jurisdictions. So Ontario has shown some variation. Europe has shown variation. So the first question I had to answer back in 2010 or 11 was, is there variation in BC? Is it worth something that I should put my research into? And so we showed variation, and it's pretty substantial. So at that time, there was no CN, which is Centre for the North. It was actually, like the data was pulled earlier, 2007 to 2011. So that's why there's the 17,000, about 3,500 a year times that many years. And so in Abbotsford, if you were a patient who's getting bone metastases treated, less than a quarter of patients are going to get offered a single fraction. And if you're in Victoria, the inverse. 3/4 of patients get offered. So that's a huge variation. Just for simplicity, I didn't put in the individual physician prescribing practices, but I have that too. And its variation is more like 5% to 95%. Like that's almost as variable as you can get. It's not 0 to 100, but it's close. So that's not good. Like we're population-based, we're a public healthcare system. Why does this variation exist? There's 25 randomized trials, right? So I thought that was an interesting place to get into. And the other thing that was concerning is despite in one of these years, I can't quite remember, the meta-analysis coming out and then Choosing Wisely Canada comes out, we started using it less often. We started giving even more multiple fractions. So we were ignoring the evidence as a population or as a group of radiation oncologists in the province. And so this is a busy slide, but it's just to show you looking at associations for relationship between different factors and getting a single fraction. And so this first one is physician's experience. So an odds ratio, so anything over 1, there's an increased odds that you are giving a single fraction. So what that's saying is for each year, there's a 1.03 increased odds that you'll give a single fraction. So 1.3 roughly for a 10-year older than a radiation oncologist. So the older radiation oncologists actually believed this. It was actually the young people coming in who were coming in and giving multiple fractions, which is too bad. And then this is describing the change over time. So for every year, there was a decreased odds of giving a single fraction. So less than 1 means an opposite association. And then different body parts make some sense. So spine is the reference group here. And so the spinal cord's right beside it. And so without getting into radiation oncology specifics, if you give one big dose to a normal tissue like a spine, there's more likely to cause harm than to give smaller doses every day, but probably not in the area of this 8 gray I'm talking about versus these 20 gray and 5 fractions. It's more to do with when you're giving 70 gray to a head and neck cancer. You wouldn't want to give that in one treatment. You would almost certainly paralyze the patient. But 8 gray is a lot less, so it probably shouldn't, but still in our psyche, we're nervous to give it in the spine. So in almost every other scenario, the odds ratio is higher. And we're actually really comfortable to give a single to a rib because there's not much there. Like there's a bit of lung, but if you're just giving radiation superficially to a rib, it's okay to damage part of the lung below it. And so we're 10 times higher odds of giving a single in that scenario. So that makes sense. And then this shows that when all of these other things are controlled for, including one I didn't discuss there, there's still a significant difference by each of the centers. So you can't, what that's saying is that you can't say the reason Abbotsford's giving less singles is because they see different patients. That's not true. It's to do with something within them. There's a culture effect within each of the centers where even when you control for their case mix, the patient's age, the physician's age, the year of the treatment, etc., Abbotsford's way less likely to give a single fraction than Vancouver, while Victoria is way more likely to give a single fraction. So we practice differently. We practice in clusters. And so that's what we concluded. So like this wasn't a randomized trial. You can't randomize that sort of a thing, but this was an association we saw. And so our hypothesis is that it's to do with we treat like our peers. And because people in Abbotsford were giving 5 fractions commonly, they saw their friend do it, they did it, and they would ask the person in the hallway, should I give 1 treatment or 5? And you're more likely in Abbotsford for someone to say, I'd give 5. Well, in Victoria, I happen to know that you would get shamed if you gave 5. And so that's part of the reason they were the opposite, is there was some really senior people who would be like, what are you doing? And they would review their cases. So probably positive reinforcement. And so what we did is we designed an intervention to educate people on this data. So not only did we have these 5 bars of the centers, we had them all broken up by physician. So Centre for the North, thankfully, didn't exist yet, but that would have been tricky because there was 3 radiation oncologists. shortly after, which is pretty hard to anonymize that because you could guess who you are. So then you'd be looking at the two others and trying to figure out which one they are. But most places, like in Vancouver, there's 20 people. We were able to show people, look, you're this red line in this bar, in these varying bar graphs. This is how you prescribe in comparison to your peers, and then this is how you prescribe in comparison to the province. And so we did that, and we had like a discussion in an annual meeting about our prescribing practices. And then we circulated guidelines, and it's not important what they are, but there's lots of publications, and the meta-analysis is one of these publications, which we reminded people about it. But what we also learned from that is that this wasn't going to be enough. People pushed back on the evidence, and they said, the patients in the clinical trials aren't my patients. So we don't randomize people in clinical trials who are old. We don't randomize people who have had something called complicated bone metastases, which there's multiple ways to define it, but some really obvious ways to define it is if you have a fracture or if you have a cord compression, well, maybe you should give more dose in that scenario. And so most of the trials didn't include them, although some did. And so people would say, well, that's just an exception. And so that was the excuse Abbott's heard, is they would say, well, 20% of the time my patients are not complicated, or they aren't poor performance status, and that's why I only do it 20% of the time. And at least we're better than the US. And so people would push back, and I could tell that wasn't going to be enough. And so I designed another level of intervention, which was to collect patients' report of their symptoms, collect it on a population basis, or as close as I could, and then do something complementary. So compare the effects of single versus multiple fractions by patients' report of their outcomes. So not enrolling them in a clinical trial where they're randomized, but just comparing the outcomes in the non-random way. Something complementary, because we've already done 25 randomized trials. So those are the two things we did. And so we'll take a little break from the impact of the education, but now I'll talk about how we designed this thing called PAUSE, the Prospective Outcomes and Support Initiative. So we decided as a group, partially led by this bone metastases evidence, but for other reasons too, that we were going to design a process where we can collect patients' reported outcomes, and it became pretty clear early on that this wasn't going to fly if it was Rob Olson's research project, because we're talking about 6 cancer centers, lots of different healthcare providers who would need to be engaged in this, and so it needed to improve immediate clinical care. So we branded sort of my research idea into a change in clinical practice. And we did that well before this was something that was popular. So this was in 2012, and just now there's evidence coming out supporting we should be doing this, but other centers now are thinking about it because there's actually been a randomized trial showing benefit to do this in the setting of chemotherapy, but we have a head start on that because we've been doing it. We also designed ways you could do quality improvement, which I won't get into, and then the population-based research, which I'll get to after. And so we started out in a very non-formal way where we just picked 3 questions, and we actually cherry-picked them from a questionnaire. We weren't a very official program in 2012, and this is just the 3 questions we asked for people when they had bone metastases. And so it was largely, the first initial question for this PAUSE program was, is it feasible to collect patient-reported outcomes in 6 centers? And so because feasibility was the main goal, we didn't want to have a 50-item validated questionnaire. So that's my defense of why we used those questions back then. We've now changed to a much more rigorous process of selecting the questions. We don't use these 3 questions anymore. But that's how we started. And also, we had to develop a big infrastructure. So it's still way cheaper than randomized trials, but it was still a lot of work because we had 6 centers, and Prince George was just one of them. We had to get nurses and radiation therapists, the radiation oncologists, PhDs, which are mostly medical physicists, and then leadership involved in letting us collect patient-reported outcomes and change how they practice every day, not just for research, but also for clinical practice. So we had to train people, we had to create workflow processes, and I learned through this to be flexible. So I came from the background of clinical trials, and so I came in thinking we need to collect the same patient-reported outcome the exact same way. We've got to use a research assistant to ask the questions. They've been trained in how to ask the questions, and we've got to ask it exactly 3 weeks later, so it's all standard. And I relatively quickly, like 3 or 4 months along the way, learned to be flexible and saying, this is complementary to clinical trials, so let's not try to do it the same way as clinical trials. It's all about getting as big a population as possible, so let's be flexible. And so I let Victoria use a clinical trials nurse, while other places would use a radiation therapist, and pretty quickly we turned into using iPads because that was more efficient, but different processes evolved in different places. And then we developed an interactive website which showed some things like this. So iPads were pretty obvious that we had to do eventually, but you can see it's not just about bone mets. So this was like 2 years ago, the number that we have. Now it's, we have to have, tree systems where you show what they are because there's so many different questionnaires we're asking. But the point is, it's on an iPad. Most everybody can see that and push those buttons. It's gone to privacy impact assessments, very valid, and then we've got different ways of graphically showing the results, so it's useful in clinic, because that's part of the buy-in, is if I don't show it to patients or to the providers, they won't want to get it. And so I needed the providers to be accruing for me, so they needed to be wanting it. And they needed to say to whoever was collecting it at their center, how come the iPad didn't go to my patient? Because they had to miss this data. And so this is old slide, but things have changed, and they're more still you know where to look, but it's gotten even more intuitive and hiding the data if it's not important or if it's all normal. But things get highlighted, and actually now we've expanded into things like screening for depression and anxiety, and including suicidal ideation. So that's our most extreme intervention. And so for that one, we have a very robust program where the system actually pages counselors. We have multiple people who get emailed so that the patient doesn't leave the building with suicidal ideation. And so it's not that common, but we have that. So that's like the extreme system. Most other ones, there's dashboards and other ways for you to follow up on what your patient has done. And so that's what we did, mostly so I could get some data. But in the meantime, I kind of found myself going from a researcher into somebody who is helping change care processes. And so we collected over 40,000 patient encounters across BC. I don't know why there's an extra C there. And we've been able to do research with it. And so it's about 3,000 or 4,000, I think, of those are bone mets. Or 8,000, but half of them are repeats. So we could do some research. And importantly, it's a really high response rate, about 90% in bone mets. So that's very different than clinical trials. Like 10% of the people you approach will say yes. So not randomized trial, so you can't assess causality, but I think it's very complementary. And it included people who were old, people were okay with answering 3 questions even though they were on a stretcher. Well, you would never think about accruing somebody to a trial usually when they're coming from hospice. But actually we captured these people because they're like, oh, 3 questions, I'll answer that. And so this is almost the same results as the randomized control trials. We found that a single treatment was just as likely to have a pain response as the 1-week course in BC. So nobody in BC really gives 10 or 25 treatments. It's either 5 or 1, really. And then complete pain response was very similar too. We did find a difference, though, for people who had these complicated bone metastases. And so we actually found that people who had complicated ones, like a fracture, for example, were more likely to get a complete pain response if they had the higher dose. Will that change practice? I'm not sure, but it actually was useful when I was feeding this back to the physicians, because they found it useful that they could see, oh, well, at least you could detect a difference if there was one, and it was just in that little small subset. So it gave some believability to the results, I guess. And so ultimately, did someone have a question or someone log in? Okay. So the ultimate question from that was, did we change practice by feeding back these results and that interventional education session I talked about? So we did. And so we now have the highest report of the use of single fractions anywhere in the literature. So there's been some specialized places in Ontario, like a specialized bone met clinic that's close to this rate, but as a province, we are prescribing the highest rate. So it's good. We changed practice. And this is not a small number of patients. This is a lot of patients. And this actually had a very, a measurable impact on wait lists. When you give less fractions, you actually open up the ability for a breast cancer patient to get their treatment a week earlier. It's kind of obvious, and it was less expensive. It really, it had a big impact, and, administration noticed. So practical with relatively little expense. And then this is just an updated slide showing that it's mostly maintained. It started to go down again, so maybe I need to design another intervention. But still, we're still high. We definitely had a big impact. And then what I found interesting is that in 3 of the centers, so this is based only on the data that I pulled from 2013 because I wasn't motivated to make a new slide. This has actually gone to 37% in Abbotsford now, and these guys have gone somewhere in between the two. And so we're reaching a more normalized point. I think it's good. We're standardizing our treatment. Like, we're not robots. We shouldn't all be following guidelines, but we shouldn't be varying this much when there's 25 randomized trials. So I think that's good. The impact of this intervention is, I think, pretty clear, despite it not being a randomization. And then this is just showing that most sites had an impact. Where it was already high in ribs, it didn't really change, but some of the places that were low had a bigger impact, like the skull. And this is just every single tumor site, whether you had GU's prostate, mostly, breast, lung, like they all went up. That's the intervention. And then just like, you've got okay self-esteem when you can put a slide of yourself, a picture of yourself on a slide. Anyways, this is just showing that it was visible internationally, and I took these slides for a different talk, trying to convince people we're doing good research up here. But it's important that, we led this intervention in a relatively inexpensive trial, and it made news in the U.S. So the Radiation Oncology Conference has 10 press releases a year, and, we had one of them. This is a big deal. It's not usually a Canadian researcher, and it's usually not somebody from a small center like us. So I think that's good. And then the next thing I'll talk about is where we're going with POSI now. I kind of already hinted at it, that we're accruing quickly. And this is older now, and it's starting to pick up. And once the chemotherapy groups, the medical oncologists, start collecting data, it's going to go up even quicker. And that's actually where there's been randomized evidence showing that there's a benefit to collecting patient-reported outcomes in a clinical setting. So it's going to keep going, and there's just going to be ripe for so many questions. So I talked about something like, I think, 7,000 or 8,000 of the cases are bone mets in our 40,000. So there's lots of other things I'm collecting data on that I haven't asked questions about yet. And it's just, we're collecting this, it's kind of like a biobank, but it's a patient-reported outcome bank. And so there's lots of questions you can ask. And the closer you get to population level, the more useful that data is. Less selection bias, et cetera. And this is just showing, again, probably a year ago where we were. So it's not important, but bone mets, brain mets, lung, gynae, prostate, breast, and then we started expanding to other sites. Now, so one of the criticisms of my research is that you can't prove that my 2 interventions actually changed practice. Like, maybe it's guidelines that somebody else did that changed bone mets. You can't really prove it because there's no causality. And so I've designed a randomized trial, which again is pretty inexpensive compared to the standard randomized trials you think of with patient intervention. This is a randomized trial of giving physician feedback. So instead of having a meeting and giving it to everybody, this is giving people their prescribing practices in the context of their peers, but only giving it to half the people in BC. So I did this a couple of years ago for breast cancer in 6 different scenarios, and so I'm just waiting for that data to mature because I had to then wait to see. I'm hoping this week to get the bone mets data. But I've also designed a couple others. But this is just an example. So I'll randomize half of the radiation oncologists to get data, and I'll say, like, Dr. X or myself. That would be a bad example. Dr. somebody else, say Dr. Miller in Prince George, she gets to know that she prescribes whatever we want to say. This example is actually how often do you give radiation in the last 4 weeks of life. So this is me trying to steer people away from treating people who are close to death. And so this isn't Stacey, but just imagine that this physician actually is doing it more often than their peers. So this is giving them a signal. You treat patients, maybe more aggressively than you should be. And then this is how you sit compared to your average in your center versus all the radiation oncologists. And then these two obviously don't line up. This is actually me, to be honest. This is me for lung cancer prescription, where I sit in the province for giving. So unfortunately, in this scenario, people with bone mets, almost 15% of the time when I give a lung cancer patient radiation for the bone mets, they die within 4 weeks. That should be a warning sign for me. But the strange thing is we don't know this. Like, people aren't giving this kind of feedback. So it's just weird that in physician culture, we're just considered so special. Like, we just think that nobody needs to challenge me. But it's changing, and I'm okay with being the person that's pushing that in BC. I'm okay with, being kind of not liked in some scenarios because I pointed out how people are prescribing. But like, this person is probably going to be like, I actually don't know who it is. I can't remember. But like that should be a wake up sign for that person that 36% of the time, over a third of their patients die within 4 weeks. they're probably being too aggressive. So, but my test is only half of these people are going to be given their prescribing. So I'm actually just using one of the medical students actually is going through this to help me create these mailouts. That's being sent out next week, and then in a year from now, we're going to see if that had an impact. So that's an example of research you can do, and then that's almost a free study, right? So this is just taking retrospective data and then getting a medical student who essentially are free, and then getting them to do a bunch of work for you. Or a UNBC student could be a part of this. And then you wait for a year. Like, you're not doing anything else. You're just waiting. And maybe we'll need to design other interventions of, like, maybe we should give 4 mailouts. Like, I don't know. But like, I'm hopeful that this will, like, change the practice of how we do medicine. Like, surprisingly, I think this will be the first randomized trial of intervention that any healthcare providers done. Like, I don't know, like, I've looked it up and I can't find any evidence of any scenario where we've done this. So I think that's something that we should keep doing, and I'm excited to keep doing this, and I want to do it with chemotherapy, and maybe we can do it in family practice, and something you can lead from Northern BC. You don't need to be in Vancouver or Toronto. So these are the ones that I'm doing right now. Another bone mets within these scenarios, breast cancer, which, like, totally different prescribing scenarios. Like, should you give a radiation boost to the surgical cavity in women under 50? It's just an example. Different technical issues that there's evidence for, and then just showing people their variation. So I guess I was supposed to highlight things for opportunities where people could get involved. So that one is just coming out. So I'm thinking like that. So there's a whole bunch of data just in describing the prescribing practices, which I could publish with many different students, and so I'm interested in recruiting people to do that. But also in a year or two from now, when the data comes back, we'll be looking at the results of the randomized trial. So the other things that I've done, this is more common epidemiology type research, is looking at variations in outcomes. So I already described, I had to look, is there a variation in single fraction prescription in BC before I could design the intervention, obviously, because if it's not a problem, you shouldn't research it. And so there's a couple things that we should just really check and we suspect. So we suspected this and we proved it. Mastectomy rates are higher in Northern BC, and as you'd probably expect, take a step back for the non-radiation oncology people. So in general, when you have a really early breast cancer, you can have your entire breast removed, or you could have just the lump removed and get radiation. So really, and they've got lots of randomized trial, again, showing about the same outcomes. There's subtleties. But so you could choose those. You could choose to keep your breast, but you have to come for radiation. So as you would expect, before Prince George existed, a lot less people in Northern BC decided to have radiation or lumpectomy, and they chose to have mastectomies. And now I suspect it's gone up in Prince George. I don't know if it's gone up in Terrace. So that's part of the question. Putting a center in Prince George, is that enough to change practice in Terrace and HRI? I don't know, but we should look, and I don't know why we haven't looked yet, because I don't have limitless time. But again, an orange box for an opportunity for someone to help me for a project we could look at. Again, it wouldn't be looking at causality, but looking at the temporal association. Unfortunately, outcomes are worse in rural BC. Now, that's not because we have worse physicians, I don't think. I think that's because we have worse lifestyle. And so because breast cancer is a relatively indolent disease, the other things trump or have a bigger impact. So lung cancer isn't that much different throughout BC because it's a crappy disease in general. And so your other healthcare or your other lifestyle factors have less of an impact once you've got it. Well, breast cancer, lots of women live for decades. And so if they are smokers or if they don't exercise or if they're obese, that actually has a negative impact on their survival. So competing risks is probably what it is. So I haven't put that as an opportunity because I haven't risen to the challenge to try to figure out how to do that yet. But that's something that we could look at because we know that we have worse outcomes. And certainly that's one of the reasons people wanted medical school here. That's why people wanted research up here, is because we want our outcomes to be better. So we should rise to that challenge. I just haven't come up with a hypothesis yet for breast cancer. Then another example is in Haida Gwaii. We were invited to be involved in a research study just looking at all of their cancers over the last 30 or 40 years. And we actually did find some differences in some incidents. So mostly everything was the same. And this is actually a unique little community where you could look at that because the First Nations people and the non-First Nations people have other similar demographics. They all live in a rural location. It's not like comparing, Telqua with Vancouver. Like there's just too many other things that are different, right? Well, at least this, they have lots of other things that are similar. So it's a better way to try to assess causality of your actual ancestry when you have that population. And so we actually did find, not published yet, but that breast cancer incidence was higher. And so it leads to questions. I again haven't risen to that challenge yet, but maybe there's a genetic factor or something. But I need to. I'm actually getting other people involved because I think it's kind of a hot topic and politically charged. So like I want to really make sure of that data. And then the other one is head and neck cancer. So I treat head and neck cancer. Sorry, acronym HN is head and neck cancer. So pretty common cancer, actually number 5. So not one of those publicized ones. Used to be caused by smoking and drinking, now caused by HPV most of the time, so a relatively common diagnosis. And I want to know, was there variation by rurality? Again, maybe designing other studies. And I just cut and paste a bunch of slides, sorry. So previous studies have shown that higher volumes of practice do better. So, and people are pretty proud of this because it's actually a pretty complex treatment site. It's just technically more difficult than treating a breast. When you're a radiation oncologist, the anatomy is quite complicated. And lots of people have published in the US and other places that you shouldn't be treating head and neck cancer if you live in a small center because our outcomes are worse. I'm skipping some of that background. So Ontario showed it. And they showed it pretty significantly that depending on where you live. So the 5-year overall survival was highest if you went to Toronto and you got your treatment, and it was lower in some of the other communities. And so it made me think, well, we should look in BC. We should know if this is true. And it actually, so I had lots of challenges to me saying, should you treat head and neck cancer in Prince George? So Red Deer and Lethbridge don't in Alberta. They decided to open up and treat simple sites. And we decided to be complex and be associated with the medical school and be academic. And so we do treat it. And so I wanted to check to see is that a good idea or not. And so that was the objective of that study. It was to look at the effect of our center and outcomes in 2006 to 2011. Sorry, these are all the centers. It's a relatively big study, 2,500 patients. There's some differences by center. So these centers give radiation alone, while these centers give chemotherapy a bit more commonly, just showing that there's differences. And so we actually didn't find a difference in overall survival. So I didn't show the slides for breast cancer, but breast cancer actually shows a big difference. Like if you live in urban BC, you do better than if you live in rural BC. We didn't find that in the 5 different centers. And so then we also decided to look at the local health authority size. So large, Vancouver, Kelowna, no, not Kelowna. Vancouver is large. I think small is actually maybe Kelowna. And then we would actually count as rural, less than 100,000. No, we're small, and rural would be like Terrace. And so we didn't find a difference. So it's reassuring. And we also looked at physician case frequency, because other people have shown that if you have a higher volume of practice, you do better, and we didn't find that association either. So it was actually a negative study, which is useful because you shouldn't have done an intervention then if you didn't find a difference. Lots of challenges from other people when I presented this. Sorry, this is multivariable analysis. And people saying, well, how could you be so different than the US? Like, we've shown this. And actually, I could not publish this in a big radiation oncology journal. A little ticked off about it, but they kept giving me feedback saying, you can't publish this because this will harm the US. This will harm the US, and that you'll give justification to small centers to be able to treat head and neck cancer. And so I tried to say, well, like, I wasn't testing that. I had a hypothesis. I tested it. I used rigorous methodology. But like, essentially, they didn't want it in their journal. And so we published it in a European journal, which they're similar to our practice. But in that process, they kept trying. The good thing is that the US journal tried to get me to hypothesize why we didn't find a difference. Still didn't accept it. But some of the things that it could be is that we're actually a really well-coordinated program. So I sit on the head and neck tumor group just like someone in Vancouver does. And I have meetings, I present my cases, I ask them for help. I trained in Vancouver. I only treat 3 tumor sites. If you work in the States, sometimes you're the only radiation oncologist and you treat everything, and you maybe treat one head and neck cancer a month, and you just forget about doing important things because you're just really busy and you don't have that specialty. But I think that we've got a big support net, and then importantly, we have awesome support staff in the cancer agency. So like we have a speech language pathologist in Prince George, and as far as I know, they're the only person who's treating outpatient. Any outpatients at all of Prince George. Like there's like, so we have one in our building, but we don't have one in like UHNBC or in the community. And then we've got dietitians, nurses, and lots of other things. So we're just a really well supported group. And then we also review our cases. So I can ask somebody in Vancouver to look at the way I do my treatment, and they can tell me, no, I would have treated this as well or adjusted the radiation in this way. But we didn't find a difference. And so some of the updates, though, is that I'm starting to update the timelines to include Center for the North, and so I would like to do that. But that's sort of like a more standard epidemiology approach is describing prescribing practices. Describing outcomes. And then the other one was early mortality, which I'll try to go through quicker so we can just ask questions. This is, sorry. Again, head and neck cancer. We want to see if there was early mortality in head and neck cancer patients, and to see what was associated with it. So people dying within the first 90 days, kind of like one of those reality checks that I was talking about, treating people with lung cancer and they're dying relatively quickly. We want to see how quickly are patients dying after we treat them. So surgeons actually routinely get this kind of information back, but for whatever reason, radiation oncology doesn't have this fed back to us. So we want to look at it. And we want to look for potential things where we could intervene, which we haven't done yet. This is a bigger age range or time range, 1998 to 2014, so over 5,000 patients. Anybody treated with curative head and neck radiation. And then anybody within 90 days mortality is what we defined it as. And then we did chart reviews and standard multivariable analysis, but we also did something called recursive partitioning analysis to try to put them into categories to say you're at really low risk of having early death, and these are people at really high risk of death. So we could use that in the future to say, alarm bell, should you really be treating people this aggressively? Or is there something else you can do to make sure that they don't die early? This is not for you guys, but this kind of a standard split of head and neck cancers. Again, this is probably not that interesting to you, but lots of patients have nodal disease. That's what N1, N2, or N3 means, and this is how big their cancers are. Most of them are T2. Not that interesting to you guys, but the type of technique we use, so almost every single one in Prince George gets IMRT, which is just a fancy way of giving radiation. We're very technologically advanced up here compared to the rest of the province, and then some of them got chemo, and then some had surgery first. And it was a bit higher than I expected. 3.6% of people die within 90 days. I was not saying that to anybody. I don't know anybody else who does either. We don't usually tell our patients there's almost a 5% chance of you dying within 90 days. We're usually telling people you've got one of the good cancers that we can cure. So this has changed just my practice, even just in a very practical way, that this is now part of my consent document or the discussion. And we found some associations. So obviously, the older you are, the higher your hazards. Okay, so for every increase in age, your hazard ratio goes up 1.05. And then there's different tumor sites, which are not important to you guys, as you'd expect. Reference is stage 4, so the lower stages have better outcomes, lower end stage have better outcomes. But then a kind of a practical thing is that you could put them into groups. So this, unfortunately, is not a great number for how predictive it is. What that says is lots of other things than what we're describing here predict for their death. But still, we can still put people into bins. So if you have really early stage disease, you have a really low risk of dying in the first 90 days. But if you're over 85 and you have nodes, 1/3 of those patients die within 90 days. We should maybe rethink that. So it's just a challenge, really. It's not like we can't really change practice based on this, but we can think about other questions to ask. But we can maybe look for what are the causes of early death. So, the primary tumor, so if you didn't treat aggressively, they would have died anyway. So that's kind of reassuring in a way that it's not caused by us. Cancer spreads, unfortunately. But then these ones are things that we should really look at. So unrelated, I can't really, but like pneumonia, this actually makes sense. Might not be really obvious to you guys, but when you have a cancer in your base of tongue, like your back of your tongue protects your airway when you're swallowing. And so you're always swallowing spit throughout the day. Now I'm like feeling choked. And so, but if you don't have a functional back of tongue or your epiglottis it's got cancer involved in it, it can just trickle down into your airway. And so actually 0.5% of our patients are probably dying from aspiration pneumonia. We can do something about that. So we can get a speech language pathologist to do a video fluoroscopic swallowing study and put in a feeding tube for the people who have a non-functioning swallow. But we don't do that at all of our centers. I haven't yet looked to see if it varies. Like we just presented this couple weeks ago at our conference. But maybe there is centers that don't have an SOP, don't do this as often, or people who don't do those studies. So that's something that we could action on. And so it's a useful thing that you can do these relatively inexpensive chart reviews for, to sort of look for areas where you could intervene. And so I think that's probably the highlight of ours. So it's not that important. It's a big study, higher than I thought, and there's certain groups like elderly people who have a higher risk of death. And so I think now you can change practice right now. You should counsel people. If we know this information, we should tell them, like, there is a 4% chance of you dying in the next 90 days. But don't say that to somebody who's 50 and has an earlier stage cancer, but you maybe say more than 5% to somebody who's 80. So this is now I need to educate the rest of the oncologists in the province and internationally, so this is something that they're aware of. And then we need to look into the aspiration pneumonia thing. So that's definitely show the green box around it, or orange box, for areas that we need to design other interventions and studies. And so I guess my real conclusion is this, that practice-changing health services research can be led from Northern BC. And the opportunity exists to not just describe the disparities, but also to improve outcomes. So I'm hoping to make it a bit more Northern BC focused in the future, but like one of the hard things about small populations is it's harder to prove differences in small populations, right? So I still think it's one of our jobs to show provincial changes and then just apply that to our practice. And so that's sort of where I've gone, just because I need big data to do it. But, you know, the longer I live up here, the more I'm being geared towards the wishes of the community, which includes looking at rural and northern and indigenous and other sort of topics. Sorry, it's kind of a whirlwind, but it gives you three big categories of what I do. So, if anybody has questions. Oh, I didn't know he was here. Oh, great. What did I say?
So I was interested in your data on.
Mm-hmm.
Do you have any data for Northern BC before we had the cancer?
Yeah, we weren't worse. And so part of it is kind of what I said about breast cancer, and that head and neck cancer is a pretty bad disease. And so we probably have higher incidence. But once you've got it, I think the survival is about the same, because I think we're treating pretty good. And people weren't doing I don't want to travel to Vancouver for my tonsil cancer that's closing my airway. But breast cancer, you know, other things could have caused their death later on, their smoking and other things. And they also it was less obvious that they needed to come down to treatment. And so they would not get things like radiation to their armpit, because it just didn't seem so obvious. It was adjuvant treatment, there wasn't a tumor there anymore, and even though there was a survival benefit, we didn't actually, it was just less obvious to the patient in Terrace. Well, when you can't really ignore your airway, usually. So, but yeah, we did have that data.
From that same study, you said that you obviously had a negative data, so you would have to. You talked about Alberta having centers, small centers that don't do those practices. So have you reported back to, like, say, Alberta? Do they have a similar system for their cancer care?
No, so they don't actually. So I think BC is an amazing place to work in cancer. So Calgary and Edmonton don't talk. So trying to get those other places to talk would also be difficult. Head and neck might be an exception where there's a little bit of conversation because it's just so important. But they don't have the infrastructure. But what it does suggest, and what I have proposed as an intervention in the paper, is maybe other places should look at trying to duplicate BC, right? Like maybe other places that are small don't have to give up and say we can't treat. They should see if they can have a robust connection to another center. And actually, Ontario is opening up to that idea. So at first, Ontario was I don't want to be quoted here, but Ontario used to be ivory tower-esque, saying, we're really great at Princess Margaret Cancer Centre, you should only come to have treatment with us. Now they've become a little bit paternalistic, but in a good way. They've started to say, we're Princess Margaret Cancer Centre, we can QA how you do radiation in Sudbury or wherever, and actually help you, instead of saying you should only refer to us. And so I would like to actually, designing an intervention would be hard, at least a randomized one, but I guess one of my jobs coming up in Northern BC is to start advocating for smaller towns, saying, actually, we can't have treatment. I used to not have that. One of my goals used to be, let's stop surgery in Prince George. Again, don't want to be quoted on that, but like that was my point of view coming from Vancouver, that I wanted to come up to Prince George and stop really big surgeries. But now I've started to realize, being here, wait, the patients won't actually accept their esophagectomy in Vancouver, so now I just need to improve the quality in smaller places. So it's an example of how you need to get someone like people like me here. Well, you need us in these communities. You can't do this research actually very well from Vancouver because your hypothesis is different, so you test it differently. Anyways, I went way on a tangent there.
No, but that's not for a lot of things.
Yeah, and we need to. Oh, sorry, this is not for everybody, but I think Paul, this is more like for you and Paul. We need to convince funders that we need to get researchers here, because you can't just put the funding into the really great researcher in Vancouver and hope that they ask the questions right, because they're just not going to, and it's not because they're not smart people. It's just because they're just not in the right context. You need us up here. Because I got converted, so somebody else would too. It's like a religion up here. So.
In providing feedback to physicians, is there already a system in place to get that feedback to them secretly? That you wouldn't just send them a feedback package in the mail, right?
So this is again, you need to be the right person in the center. So this would not go over well if a Northern Health physician sent an email to people. But I trained in BC. I know these people. I've gone to all the centers, and so I thought that probably I'd be well received. And in general, I was. There was a couple of people who were offended. But we actually got REB approval to send emails only within BC Cancer Agency emails. There was some pushback. So they wanted me to get signed consent to do this, but it was a retrospective chart review of their practices. So instead, I met with the chair of REB and convinced them that I would do an opt-out process where I sent everybody letters, and then they had 30 days to say, I don't want you to look at my data and include me. And nobody did. A lot of people complained and were terrified. And a lot of people pushed back. So people would send me feedback on, are you sure this is right? Where's the confidence intervals? All these different people got pretty personal about how they prescribe in the context of their peers. But in general, people actually are pretty receptive to it, especially because I'm not putting up their prescribing practices for the whole world to see with them identified. So it's somewhat secure, I guess, is the answer to your question, and approved by ethics, right? And with thoughtful discussion, and I think it's ethically sound.
Well, if it's through your internal, there's every other community.
Yeah, exactly. But still, yeah, exactly. Oh, I don't think I have to push anything. I don't know if anyone's on the phone, but if anyone's on the phone, do you have any questions? Not convinced there is, because nobody popped in.
I just have a question with curiosity. You were talking about the study in Hawaii where you're trying to perhaps to collaborate or pass off to other people around genetic factors.
Yeah.
Are you thinking about a genome-wide application study in that group?
Yeah, I need to really clarify that this is correct, because yeah, I just do. And it's such small numbers. Again, the problem with doing rural research is that it's hard to draw conclusions, but we actually found enough of a signal that it looks like it's real, it's statistically significant. Could be by chance because we've tested multiple tumor types.
So what were your in that study? What was your
500, something like that, of all cancers for 30 years. There's 5,000 people. UNBC is a bigger population than Hawaii, I'm pretty sure. It was bigger for a while from when we pulled, and then they've gone down in population. But still, really small numbers, right? But it looks like 2.5 times higher rate of breast cancer, which looks real. Yeah. But like most of the time, it's actually reassuring to First Nations communities that the rates aren't higher. Now I'm going to get way off on a tangent. Most data suggests it's actually lower, and that's actually a bad news story. It's actually because they have competing risk of mortality. So most people don't live long enough in some other First Nations community to get cancer because they die of other things at a higher rate. So that's part of what I'm looking for is some adjustment for competing factors and stage standardized incidences. But I still think it's real in breast cancer.
Any other questions? Okay, well maybe we'll
Cool.
Here for a little bit if people have no questions, but just thank you so much for coming, and I hope the students saw that there's lots of opportunities to get involved in perhaps like different kinds of research that we haven't thought about before. So Dr. Olson is based at the Cancer Agency, but he frequents the NMC occasionally.
Yeah.
Here, so we should...
Every other Thursday starting in November.
What's that?
Every other Thursday starting in November. But I have like such a small window that email is the best way to get a hold of me.
The NMC faculty, so Ross Prior, and the HRI.
Yeah.
Yeah, it's a good reminder. I think to the community, a part of the things we wanted to do. Yeah,
For sure.
Thank you so much for coming.
Cool.
Thanks.
Thank you.